general announcement.
Good morning, everyone. So this morning, we will just present our news and updates, like Vorshka said, and then move into our presentation today. So I wanted to just let you know that applications are still being accepted for the University of Colorado Accords and D&I certificate program. And I will be putting all of these links in the chat. So don't worry about trying to get the QR code. And then we will be having the Colorado Pragmatic Research in Health, or CopperCon conference, happening in June. The abstract deadline has passed, but you still are able to register and sign up to join. And then our February DISC and INSTEP seminar is going to be happening on February 20th, and we will hear from Dr. Elizabeth McGuire on team functioning and implementation of innovations in healthcare and human service settings. And this is going to be not just about the systematic review, but also results from their study. So you'll be able to register for that meeting and all of our subsequent DISC seminars at the link that I'll put in the chat. And then for our 2025 AFT meetings, I'm very excited. So we have everyone booked up until June of this year. So that's actually very exciting. And so what I'll do is I'll put the link in the chat. You can register for our 2025 meetings if you haven't already. And if you know of someone, or if you're interested in participating as a speaker for our future meetings, please submit a nomination request. And we've had a lot of great presenters come from our nomination request. So we're really excited to hear what you have going on and what you're looking to present. Now I'll pass it over to Vorshka to introduce our presenters today.
Thank you so much, Kara, and welcome everyone again. We are very grateful for your recommendations for additional talks. So please do take advantage of that link that Kara will share. We are looking for September through the end of the year presentations now, and we would love to see you present or someone else who you know. But with that, I would like to turn my attention to our great two presenters who I had the pleasure of working with very closely over the years, and they are both moving into a next phase of their career. So it's exciting to have them back, talk about some of the work that they have done together, we have done together when they were still in training. The first person listed on the slide is Alec Terrana. He's a first-year psychiatry resident at the University of Washington. His research interests are in cultural psychiatry, health services, and dissemination and implementation science. Alec has a special interest in better understanding how evidence-based practices can be adapted and sustainably implemented in novel settings, particularly when cultural factors are implicated in intervention acceptability and engagement. Clinically, he's intending on pursuing additional training in child and adolescent psychiatry and psychodynamic psychotherapy. And Clare Viglione is a doctoral candidate in public health at the University of California, San Diego, and San Diego State University, with plans to defend her dissertation in summer 2025. Very exciting. Her research focuses on equitable, cost-effective familial interventions targeting social-emotional development and childhood obesity, particularly in underserved communities. With over a decade of experience in clinical nutrition, public health research, capacity building, and implementation science, Clare has held roles with Harvard Prevention Research Center, Boston Medical Center, and New York University, and served as the director of Grow Baby, a national practice-based research network within Vital Village Networks. In this role, she co-led capacity building activities, facilitated participatory research on diet group care, and evaluated equity-oriented child health interventions using implementation science. Her clinical experience as a registered dietitian, specializing in diabetes and women's health, informs her collaborative work with clinical stakeholders to design and implement family-focused health interventions that address health disparities and advance holistic patient-centered care. And you will see that these interests, both from Alec and Claire, will nicely come together in the presentation they will give today, which is work around forms and functions, very directly linked to the idea of adaptations. And this is based on a paper that we shared with you that was published and led by Alec. So I'm going to thank them again for being here, but they both are very busy in their careers and personal lives. So thank you for taking the time, and I will hand it over to you for the presentation.
Awesome. Thank you so much. I will just get the screen shared. Assume everybody can see that okay? Awesome. Yeah, thank you all again so much for having us here today. I'm excited to share some of the work that Claire and I have been involved with for a pretty good long while now. We'll be talking today about the functions and forms paradigm, specifically how we applied that throughout EPIS and sort of shifting with the way in which we attempt to look at fidelity from more of a form fidelity perspective to more of a function fidelity perspective. So this is an overview of what we'll be talking about today. I'll spend some time just reviewing the challenge I'm sure everybody's familiar with between balancing fidelity and flexibility when implementing interventions, talking a little bit about the core functions and forms paradigm itself, and then how we applied that across EPIS, specifically within the case of the case study that we'll be talking about, the Healthy for You study. We'll going through the framework development across each of the stages of EPIS, talking a little bit about the future directions that we potentially see this going based on some of the limitations of the approaches we adopted it along the way. So I'm sure everybody's familiar with the well-established challenges of maintaining evidence-based practices efficacy when being translated into novel settings outside of the initial context in which it was developed for research. Fidelity to the protocol or the core components has this tension with the adaptations to the local context. And these considerations are often framing the implementation and sustainment of evidence-based practices, particularly in novel settings, as a bit of a balancing act in which we're attempting to keep the intervention the same by prioritizing protocol fidelity on the one hand, but then on the other, we want to be able to allow for change, to have adaptations to local context. And this framing makes this distinction between the core components that are theorized to be responsible for it being effective, and then on the flip side, the adaptable elements that are theorized to be modifiable without directly compromising impact. However, as we were thinking about this in the present study, there were a number of limitations that we came up against to this particular framing. One of which is that EBPs are often not evaluated in a way that actually lets us retroactively disentangle these elements, especially in a way that really lets us see what elements are actually core versus adaptable. This can then leave implementers in a position where they don't really have sufficient guidance around what needs to be maintained versus what can be adapted. And in a lot of cases, I think just leads to defaulting to essentially prioritizing fidelity as it was described in the protocol, which then can create not so much wiggle room for adaptation for fit with the patient population or the service context. Additionally, another difficulty that we saw with this approach is that what's core versus adaptable in and of itself might be context dependent. While it's helpful for the original intervention developer to specify what they think is core versus adaptable, these assumptions are likely influenced by the original context in which the intervention was set. And it's possible that what's core in that context will be core in another. That's by no means definitionally true. So there's a possibility for some bias here, essentially towards the prior authorization of what the interventionist felt was core in the initial sense. So to address these issues, we wanted to adopt an alternative approach to help guide adaptations of evidence-based practices in local contexts, really looking at the theorized mechanism of action or the function of any given intervention element as the core referent for fidelity. So that being said, we turn to the core functions and forms paradigm. This is a framework that was developed by Monica Perez-Hoyes, Rebecca Legnick-Hall, and Brian Mittman. And in their framing, they differentiate between core functions, which are identified as the underlying elements of an evidence-based practice that are hypothesized to be responsible for achieving its theorized mechanism of action, and then its forms, which are essentially operationalized elements that will then enact these underlying functions. And in this framing, priority is given to maintaining core functions when an evidence-based practice is implemented in a novel setting, while allowing for sufficient variability in the forms that can be tweaked to the local context, whether that's the priorities, the preferences, the resources of the adopters and the recipients of the intervention. And the core functions and forms approach has been applied throughout a number of studies, oftentimes either by retroactively identifying functions and forms after the fact, or by prospectively guiding pre-implementation adaptations. So our hope here is to extend this paradigm by developing a function form matrix that we'll be showing you in a couple slides prior to intervention implementation that could then help guide the development of the measurement protocol so that we could track fidelity with regard to both function and form. One of the other things that we sought to do with this was to overlay the function and form paradigm on top of the EPIS framework. The EPIS framework looking at exploration, preparation, implementation, and sustainment across all stages of the intervention development and implementation. It's a foundational model on which we were able to overlay the function form paradigm. And really the goal here was to move beyond the pre-implementation periods of exploration and preparation. Though during these periods, especially during exploration, the function informed paradigm can be particularly helpful in that it can help guide evidence-based practice selection towards interventions that have core functions that align with the goals of the local context. So we'll be sharing a bit about this in the context of our case study. Moving on to the preparation phase, the function form approach can then provide a structure or the matrix that can help guide decision-making, both for how to develop localized adaptations of the evidence-based practice, but also at the same time to guide development of the measurement protocols that will actually be used for monitoring fidelity, both to function and form. During implementation phase itself, we can then use the function form matrix to guide how the implementation itself is going, as well as developing the fidelity monitoring approach. And then finally, within the sustainment phase, that allows for then looking back to critically review how we want to analyze the data and the degree to which each of the forms seem to fulfill its underlying function. And this question of, what degree did the form actually fulfill the function is going to be one of the big ones that we focus on today. So in terms of the context in which we were actually studying this, this was within a much larger study called the Healthy Experiences, or the Healing Experiences of Adversity Among Latinos study, or the Healthy for You study. The goal of the study essentially was to adapt evidence-based practices for strengthening family protective factors against adverse childhood experiences, or ACEs, among Latino families in San Diego. As you can see here, there were a number of different partners involved in the study. UCSD, Family Health Centers of San Diego, as well as a number of different community-based organizations played a really key role in making all of this happen. It's really exciting just to be kind of a little sliver in this massive study that spanned a lot of different communities. And really what happened here was that team members from these various organizations partnered to co-design an intervention protocol that was built on Family Health Center's foundational weight loss program, Healthy Together, which was aiming to target contributors to ACEs within San Diego Latino community. And the goal here was then to address evidence-based practices that could augment this sort of baseline Healthy Together condition to address social determinants of health. And so through our use case study here, we wanted to, one, come up with a structured example of how the function and form paradigm could be used across the EPIS implementation framework in this particular case, as well as then to develop a process model for how the function form framework and EPIS could be integrated to account for both form and function fidelity. So in terms of the exploration phase, we broke this down into a number of different stages. In the first stage, the primary goal was just to identify what are the core functions of the overall intervention. And so for us, we felt that the core functions was that this project should serve Latino families insofar as we had the foundational goal of providing participants with the knowledge, the skills, and the resources that would support the development of protective factors that have been shown to reduce the risk for ACEs. And just a couple of these include supporting parental resilience, helping to foster social connectedness, providing concrete support, and then offering knowledge and skills related to both parenting, but also to children's social and emotional development and competence. Once we had this primary goal outlined, we then moved on to the second stage, in which we gathered data on both inner and outer contextual factors that could inform implementation feasibility. And really the goal of this was just to demarcate the landscape in which the implementation components would be implemented. So chief among these were the clinical and administrative context of Family Health Centers of San Diego itself, and then zooming out a bit further, looking at the larger cultural context of San Diego's Latino community. The next stage within the preparation phase or the exploration phase was to consider and select evidence-based intervention components based on the degree to which we felt like they would be able to meet the hypothesized required core functions within this specific context. And so the two ones that we looked at here were the Incredible Years program and the involvement of health promotores. And so the first of these components, the Incredible Years program, or IYP, is a group-based program. It's demonstrated efficacy and effectiveness in numerous RCTs and has been shown to improve parenting behaviors as well as to strengthen children's socio-emotional regulation skills, specifically aligned with protective factors that were flagged as being important for the overall trial and its aims. And we felt that choosing IYP was consistent with the goals of addressing ACEs while also addressing childhood obesity. And this particular intervention component was intended to serve the function of improving children's social and emotional competence by simultaneously providing parents with the knowledge and skills of both parenting and child development, as well as the skills to run a stable and nurturing home environment. The second component that we looked at, which was engagement with health promotores, represents a community health worker model that's tailored specifically to the Latino community, in which promotores work directly with community members to increase capacity building skills, which they do by providing education and facilitating connection to community resources and social services. And felt like the health promotora was especially interesting from a function form fidelity perspective, because there's a very wide variety of ways in which we perceive promotores as being able to perform their core functions. In many ways, this is by design, as at its core, promotores are essentially there to align with the changing and evolving needs and strengths of the families they seek. So adaptability is essentially built into what we perceived their role to be. So just zooming out a little bit, looking at sort of overall goals of the exploration phase. The first was just to achieve a general understanding of what's going to be feasible, acceptable, appropriate, usable, and likely to be beneficial within the context in which we were implementing the study, as well as then to select intervention components that we felt like were likely to be able to fulfill the project's core functions. So then moving next on to the preparation phase, the first stage of this part was identifying the core functions and the possible forms of each intervention component themselves, so of IYP and health promotores. And this was essentially guided by the idea that functions would be needed to deliver an intervention effectively, whereas there are many possible forms that can enact that function. So any individual form in and of itself might not be necessary, but it could be sufficient. But on the flip side, the functions themselves would be necessary in order for the intervention to be effective. Within stage 5, we then selected contextually relevant forms that we felt like could fulfill each of these core functions. And so the intention here is really to develop an intervention and measurement forms that would be feasible, acceptable, appropriate, and usable by all involved parties, as well as allow for operationalization, observation, and assessment by the research team. And given that this was a pragmatic study and being rolled out within Family Health Centers of San Diego, we had a big focus on gathering data that would have some clinical relevance for clinicians, so that it wasn't just, research data that we were getting, but actually something that could potentially feed back into clinical practice as we were gathering the data. Next, looking at stage 6, this involved mapping out the relationship between the intervention components, functions and forms in a matrix, which I'll show in a couple of slides. And in terms of the theories that were underlying this, for Incredible Years program, because there's so much robust research on that, they already have very well laid out theoretical foundations for that, most specifically looking at Patterson's social learning model, Bandura's modeling and self-efficacy theories, and then Bowlby's attachment theory. Coming up with the theoretical groundwork for health promotores was not quite as clear-cut. We ultimately decided to go with the 5A's model, which was actually initially used for smoking cessation, because we felt that while a big part of the promotores role does involve offering concrete forms of support, we felt that their primary mechanism effect was actually relational, allowing for these dynamic adjustments based on the family's current circumstances and context. So we felt that beyond their demonstrated efficacy in promoting provision of concrete supports, these 5A's of ask, advise, assess, assist, and arrange could also serve this underlying core function by creating a relational support that would put the promotor in a position to continually adapt their position based on feedback from the family. And then in addition to these initial 5A's that have been a part of this model since its initial use for smoking cessation, we added 3 additional A's, and these were attune, actualize, and asset identification. And the goal behind these was that we respectively wanted to capture the promotor's ability to connect with the family, actualize their own capacity to care for themselves during and following difficult encounters, and then to create opportunities to highlight family strengths and positive experiences. And so that last one is the asset identification. And then finally, within this phase, we developed the assessment tools. And so through this, we wanted to develop a framework that could capture both process and outcome measures from the perspective of the study participants themselves, the clinicians who were delivering the intervention, and then ideally also from the perspective of an observing third-party researcher. And so we incorporated both quantitative and qualitative aspects into this. Claire will be talking a bit more about that. So for the preparation phase, again, just zooming out a bit, really the main goals here were to create preliminary function form matrices for each intervention component, as well as to create fidelity monitoring and adaptation documentation tools that we could use throughout the remaining phases. And so here we just have a little snippet of one of what the matrices look like. This is looking at the 3 A's that we had created on top of the 5 A's that have traditionally been used. Specifically, this is for Promotoris. And so you can see on the left side that we have each of the functions laid out. Then we have potential forms which we thought could potentially be used in order to actually enact this particular function. And we've come up with all of this prior to the study being implemented, both through literature review, but also talking with folks who had quite a bit of experience working with health promotoris, sort of envisioning how they saw promotoris being effective in the things that they did. And then on the right side, we have the assessment tools that we were using, both to get a sense of to what degree is this form and potentially the function actually being played out in practice, both from the perspective of the promotora providing the care, but also from the perspective of the patient and the family.
All right, this is my part. Thank you, Alec. So now we'll dive into the implementation phase, so the I of EPIS. So stage 8 focuses on gathering form and function fidelity data and preliminary outcomes data. And for this stage, we used a set of tools that we actually created, and I wanted to point out a couple of things related to those tools. We relied on mostly on checklists. And so we were more robust for measuring form fidelity than function fidelity. And the tools that we created, and I'll show kind of snippets later in the presentation, were not validated necessarily to measure forms or functions. And so this is a really ripe area of continued research. You know, we developed our tools based on kind of best practices for tool development, but there's no sort of psychometrics analysis or validity testing for these tools. And then stages 9 and 10, things start to get interesting. So stage 9 focuses on tracking implementation processes and adaptations in real time, with the goal of stage 10 to iteratively adjust the function form matrix based on that process and outcome data. And we recommend in the paper to use something like a periodic reflection style interview or a brief check-in regularly in order to track the implementation processes and adaptations, in order to really capture adaptations in real time and those dynamic changes so people don't forget, but also to really capture sort of the subtle connections and association between the forms used on the functions. And as needed to expand sort of our menu of forms for each function as well. So we're capturing data in real time and iteratively adjusting our matrix based on the information that we're gathering. You can go ahead. And then the overarching goal for the implementation phase is to produce an amended matrix that reflects lessons learned throughout implementation regarding sufficient function and form fidelity in that context. And then we move into the sustainment phase. So stage 11 is focused on gathering final process and outcomes data and evaluating function form fidelity at the close of the intervention project. And this is focused on really capturing what fidelity looked like throughout the course of the project. And then stage 12 and 13 is focused on sustainability planning. Stage 12 focuses on assessing the partner's intentions for sustaining the intervention. And then stage 13, based on the feedback about readiness and intentions to continue the intervention, we adjust and amend the matrix based on those intentions with a potential modified matrix for continued implementation. And the goals for the sustainment phase are twofold: to assess the degree to which function fidelity or form fidelity influenced EBP effectiveness on target outcomes, and 2, to update the matrix to foster sustainment in the local context, or potentially to disseminate this modified and updated matrix to a novel context and to test it out in a new location.
And so here we just have a summary of a lot of what we shared, kind of just here for reference, sort of just running through what the goals were at each of the EPIS stages, and then sort of breaking down individually within each of those stages what we envision the process of this looking like. So in terms of kind of overall reflecting on this a bit more, our thinking was that by outlining the process by which researchers could adopt the function form perspective throughout EPIS, we were hoping to expand the ways in which fidelity is studied. So this would theoretically go beyond kind of parsing out the necessity of individual intervention components or the forms by looking more so at the essential processes or the functions by which effective components are actually hypothesized to work. Identifying these functions would then allow for defining fidelity reference in reference to these functions as well as forms, so that there's a little bit more flexibility in local environments. And our hope here was really to shift away from using fidelity reference that are based solely on the prior authorization of interventions forms, which we think about as having more of form fidelity, to have this approach that shifts towards more of a function fidelity. And theoretically, this would then allow us to prospectively adapt interventions in a way that allows for greater responsiveness to implementation context while still keeping sort of the secret sauce or the core mechanism of action intact. And in addition to sort of this just potentially leading to having more effective interventions when they need to be adapted, another big piece of this is that we think it also allows for a lot more robust and meaningful opportunities to collaborate in co-designing the intervention with project partners, particularly those who are directly involved in either delivering or receiving the intervention. So again, this is a big part of where the idea of the periodic reflections would come into play, sort of actively incorporating that feedback into making adaptations. In terms of future directions of this, I think these are a lot of things that we sort of teased out retrospectively, things that maybe we felt like were limitations of this approach and could potentially be done better in the future to provide some additional rigor to how we went about this. This would be the case in a number of different areas. Insofar as the first one would just be having greater rigor in assessing candidate forms early on to established evidence-based and inclusion criteria for what intervention components actually get included in the overall intervention. One particular method that we think could be really helpful for this is CORE, or the Components and Rationale for Effectiveness Fidelity method. This is a novel method that defines key components of evidence-based interventions for effective implementation through developing a detailed description of the core components as well as hypothesized rationales for their effectiveness. And our thinking is that by using this could potentially have more rigor in actually making the initial selection, whereas we'd gone through selecting IYP and Promotoris. There could have potentially been a little bit more of a formal method behind how we went about doing that. Similarly, I think there also could have been a more refined assessment approach that we use to operationalize adaptations. There are a lot of different frameworks for this, just listed a couple of them out here. But do feel that having a more systematic approach could promote greater confidence in linking the functions with the forms that are ultimately delivered. And that theoretically, this would also allow for a bit more accurate disentanglement of forms from functions by having just a more structured framework for how we looked at them. And then the final area in which we feel like some additional rigor would be beneficial, but also probably the most difficult to have done, particularly within the context of this study, would be to develop screening experiments that themselves could then more rigorously test which functions are truly necessary to produce the desired effects before they're rolled out on a larger scale. So Linda Collins' MOST, or multi-phase optimization strategy, could be potentially helpful here. Which would involve having this initial screening phase in which we are looking at intervention components to efficiently identify, inclusion, whether or not they should be left in or left out based on their performance. Then a refining phase in which the selected components are tweaked, and questions such as optimal component dosage are investigated to figure out what is the best way to go about implementing this particular component if we feel it is effective. And then finally, a confirmatory phase in which the optimized intervention consisting of optimal doses of the selected components is then evaluated in a standard randomized trial.
All right, thank you, Alex. So for this last part of the presentation, I'll share a glimpse into a work in progress. That's sort of a side project or a sub-evaluation based on the foundational work of the forms and functions. In part, this work is for my dissertation. So the purpose of this implementation kind of sub-evaluation is to look more specifically at equity in the implementation of Healthy for You, focusing on reach, adoption, and again, fidelity, but I'll be utilizing the PRISM framework for this evaluation. And the data sources are multiple and complementary. So we're looking at EMR data and demographics and health data to look primarily at representativeness. We have a number of different sources of data from the implementers and the implementation team. So they documented after each clinical encounter and kind of therapy visit, whether it be the promotoras or the mental health clinicians who were conducting the Incredible Years intervention. They have their post-visit forms checklists that were completed. And the mental health clinicians who were kind of clinical staff at the FQHC completed progress notes, which we edited, and I'll show you kind of an edited version of this, where they were sharing forms and function information in that progress note. And then we have provider focus groups where we expanded on context domains of PRISM, participant interviews, and a number of different participant surveys getting at sort of effectiveness of the intervention, but also feedback and perspectives on implementation. So this is the PRISM framework. I'm sure you all are very familiar being a part of this group, and so I won't go into detail, but I just wanted to emphasize that PRISM and REAIM outcomes do address equity issues and prioritize equity in multiple ways by addressing context and the external environment, by prioritizing multiple perspectives, by looking at fit and specifically tailoring interventions to specific contexts. And then, of course, in reach and adoption, looking at representativeness and engagement of multiple groups and underrepresented groups. So I am sort of addressing equity in the implementation of Healthy for You, looking retrospectively at what happened, but using PRISM as a lens to do that. And so these are the key areas of this sub-evaluation. I just wanted to share a little bit more. So for reach, we're kind of looking at more of a standard way of looking at reach. So looking at participant demographics from the EMR and comparing who enrolled and participated and actively engaged in the intervention compared to the Family Health Centers of San Diego FQHC population at large, which is a largely Latino population. So the research question is, to what extent does the intervention engage and represent diverse subgroups by SES and by ACEs also, compared to the broader patient population served by the FHCSD or Family Health Centers of San Diego. And I'm also utilizing the forms functions fidelity paradigm, really capturing, making use of this matrix to evaluate fidelity throughout the intervention. And so again, we're relying on our forms checklists that we've developed, and those are through the post-visit assessment forms and the EMR progress notes, as well as combining with our complementary STAR assessments, which are a therapeutic alliance measurement to get at connection between the parent and the provider, both the mental health clinician for the Incredible Years part and the promotora. And so the STAR assessments, I'll share in a moment, I'll share some of the questions from that, but we're combining the STAR assessments with the checklist to get a more holistic picture of forms and functions information throughout the intervention. And so the question there being, to what extent are the interventions forms and functions delivered consistently across key demographic subgroups? Are there any themes there that help us better understand equity? And the reason this is interesting and important is because a lot of health interventions, as we know, especially thinking about digital health interventions, kind of unintentionally exacerbate inequities by kind of serving one population better than others. So I'm really interested in this area of work. And then finally, exploring the PRISM context domain, specifically organizational, implementer, and external environment factors via provider-specific focus groups that we just concluded with each set of different, so we had a promotora group, we had a primary care clinician group, we had an MA group. So there were a lot of kind of clinical staff involved in varying roles. And so we had focus groups where we expanded on PRISM and talked about sort of each dimension and how that might have influenced the intervention, but then brainstormed ways that that might have impacted these external kind of social drivers of inequities might have impacted reach, adoption, and fidelity throughout the course of the intervention. So we're currently analyzing that data right now. So this is a table of to describe how we're operationalizing mixed methods through PRISM. And so you can see on the left-hand side, we have our PRISM context domains and then the REAIM implementation outcomes, and then the quantitative dimension of how that is assessed, and then the qualitative component that kind of aligns with PRISM, and then example interview questions that we've used both in participant interviews and then provider focus groups to get at those specific domains and areas within PRISM. And so happy to go over it. This is a very busy table, and happy to answer specific questions if there are some at the end. So Alec also shared a snippet of the matrix. So this is the one kind of function that I wanted to highlight, which is to build positive rapport with both parent and child, which is associated with possible forms, psychoeducation, problem solving, or behavioral practice using worksheets and handouts. This is for the Incredible Years, which the program is highly manualized and operationalized already. And so we had a lot to pull from in terms of potential forms that would get at the functions. And so we had a very lengthy matrix where we had the functions and then the sessions within the Incredible Years and then the possible forms. And this is how we kind of implemented or operationalized the matrix within the context of the electronic medical record progress note. So this is the standard progress note that the mental health clinician completes for their individual one-on-one assessments. We added what is highlighted in yellow. And so for this first part, we added around mode of communication to get at delivery. And then if you go to the next slide, Alec, we added what is also highlighted here around questions around problem solving or solutions, suggestions around the visit. But then in green, it gets at the forms. So specifically, we ask about the session of Incredible Years and then the forms that were used to kind of accomplish that session. Psychoeducation, problem solving, did you set a SMART goal, role play, et cetera, to see if it aligns with how our matrix was conceived. If you go to the next slide, then we have just a snapshot of the STAR assessment, which is this therapeutic alliance measure. And so we conceived that the connection between the parent and the provider, or the patient and the provider, their alliance, trust, rapport, their bond was a key function for both Promotora intervention and the Incredible Years intervention. And so we had this STAR assessment, which was nicely aligned with that function that we texted in real time post-intervention, post-visit to both the provider and the patient to ask questions that align with each other around openness, trusting relationship. You can see my clinician and I share an honest, open, trusting relationship, and then a scale to measure that. And the provider also filled out a complementary version. And so that gets at those core functions. And so I think that's all we have in terms of content for today. And we have a list of multiple discussion questions. I'll just read them off to have people start thinking. And then I know that I think there's some questions and activity in the chat. So how might you apply forms and functions to your work? How do you envision forms and function combining with frame or more sort of robust adaptation assessments? What additional methods or frameworks could strengthen the robustness of our evaluation? So any suggestions or advice or guidance for what we could do better in the future? What are your lessons learned or experiences from assessing fidelity? How have you interpreted variations in forms and functions? Specifically, I'm very interested in these variations or what we might find amongst different kind of subgroups. And what have been your key lessons learned from similar implementation studies that can inform the next phases of our work? Thank you. Thank you very much for your time. Thank you, Borshika and Russ and Kara, for the invitation to present. We really appreciate it.
Thank you so much, Alec and Claire. This was fantastic. And of course, your time management is superb as well. That's what I would expect from someone who is working in different sessions and therapy sessions, really well timed. I have a few questions in the chat, but I wanted to see if anyone would like to unmute and start with the first question. And if not, then I will pull from the chat. Let me see. Okay, well, I will start with one that I pulled from the chat. Then I would like to encourage everyone to prepare your thoughts and then, put on your camera if you can, or just unmute and come in with your questions. One of the questions was very simple. Is it published? Is this work published? And I think there is a part 1 and part 2 to this answer. So I will let Claire and Alec explain which part is published and which part is not yet published.
So the part that I had spoken on is published. I'm happy to drop a link to that in the chat. But I believe Claire is still ongoing. I'll let her speak to that.
Yeah, still a work in progress for the kind of additional pieces of the evaluation, with plans to hopefully finish by June. And I dropped the link in the chat to Alec's paper.
Okay, that's very helpful. And Claire, I hope that you will be presenting on this in different venues, and we'll see this work published as well. Russ is wondering, how did you find the 5 A's or 8 A's framework to work?
I would actually have to defer to Claire to that one. To be perfectly honest, my involvement in the study was primarily all up until implementation. So I don't know how it played out in practice. I would be curious to hear the answer to this as well. I think it made a lot of sense in theory. But yeah, not sure how it played out.
Yeah, I think so. We had the checklist and the questionnaires for promotors to fill out after each session. And we had all the kind of 8 components there and had them fill in their conversation elements that were a part of each A. So from, a cursory review of this qualitative data that we're getting back, it seemed to work nicely and to align with the kind of goals of each conversation. But some A's are definitely more sort of robustly discussed than other A's. And it will be interesting to see when we do analyze that data, kind of maybe some themes or patterns that emerge, that maybe that assessment was easier than attunement. For example, attunement is something that we added. But I also want to emphasize that I think we weren't directly observing or recording these conversations. So there could be some really expanded evaluation of the functions of these promotor visits as well.
Thanks. Appreciate that. And first of all, overall, great job on this. Such a comprehensive evaluation that you've done, or application of this, and integrating different frameworks. Very, very impressive. The reason I ask about the 5 A's is I've been a huge fan and used it a lot over the years. It's worked well for us. I personally liked your expansion to the other A's, and I was curious about that. But in other people's application I've seen, even in smoking, but also particularly other areas of behavior change, they've generally gone the other way to reduce it even more. The number, I'm not sure how far you follow the smoking literature and things, but often now, many of them are only using the first 3 A's or whatever. And I've seen particularly on things that involve some referral and follow-up. But anyway, I was just curious and frankly kind of encouraged to hear that it seems like the full range would work there. But I was just reflecting on that, why in some areas, some people feel anyway that it's even 5 is too many.
Yeah, I do. I think 8 might be a lot. So we'll see kind of some patterns that emerge. Alec, I don't know if you want to speak to how we came up with 5 A's. I feel like with the promotoras specifically, we wanted it to be as open as possible. And really, we were just trying to, the promotora can help the family with whatever. And so really helping and bonding and connecting with the family was the primary function. And then we thought that 5 A's was open enough to kind of align with that function. But Alec, I don't know if you remember kind of any specific details around these. We had numerous conversations trying to come up with a framework that could fit.
Yeah, and I think in a lot of ways, sort of the use of like incredible years versus Promotoris set up kind of introverse or interesting parallels in that like incredible years is so incredibly protocolized. Like it was basically all forms and the functions are outlined, but really it was all about the forms. And we actually had to adapt IYP quite a bit because doing IYP properly just would not have been feasible within this context. So that was very much a form fidelity focused approach. Whereas the Promotoris, very open-ended. There's a lot of literature on health Promotoris, but in terms of like actually operationalizing what that is, specifically outlining what that they do, that isn't quite so much in the literature. So we felt like the 5As sort of allowed for this open-endedness. I think, to Claire's point, maybe we did get a little bit carried away. I think 8 is too many. And that I think limited our ability to like actually really hone in on specific things that they were doing. But I do think it was so rooted in a function-based approach that it seemed like that would allow us the flexibility to capture that, even if it ended up being a little bit tedious and like over-involved with having so many different parameters on which we were trying to track things.
Thank you so much. Great discussion. Let's see if anyone is ready to unmute and come on with questions. I have a question about this idea to use the matrix iteratively and change it over time. I think that's a great idea. Often the way that I have used the matrix is that we determine either retrospectively most of the time or prospectively what the functions and related forms are. And then we document adaptations, but we don't necessarily go back to the matrix to, change it, to adopt it and reflect how things are playing out in the real world. So I just was wondering if you wanted to say anything about this idea of iterative use. Have you ended up using it that way in the study during implementation and, the sustainment phrase, or do you have any other thoughts for future use?
We had a little bit of a challenge with this project that it was very, very slow to start in an FQHC setting, like many probably have experience with. And so sort of the steady state of where we wanted to be with multiple visits happening in order to do like meaningful periodic reflections, we didn't quite get there. And so the goal of iteratively using it, I don't think we met that, but we want to adjust it now based on the feedback from the kind of the end and our focus group data and some of the provider interviews and reflections, but we weren't iteratively adjusting. But that, I think we talked a little bit more about this in the paper. Ideally, it'd be really neat to iteratively adjust, but then also design like mini rapid feedback cycles in order to have certain goals of what you want to see and then sort of test those in sort of quality improvement practices of sort of rapid feedback cycles.
I think this is also probably another area where having additional rigor would be helpful, is that if we were getting that feedback in a timely enough way, having a systematized approach for like, how do we incorporate that and then reintegrate that back into the matrix? We hadn't come up with like a specific protocol for how we would do that. So I think it would have been kind of open-ended and diffuse. So yeah, I think as in a lot of areas of this was more exploratory, but having just a little bit more systematization to like how we actually went about reincorporating feedback, I think is something that could be helpful if, we were to continue with this approach in other settings.
Yeah, I like that. And I was thinking, and Ross is pre-warning everyone that if you are not asking questions, we will continue. We are having a really fun time. I'm just trying to hold back. But I was just reflecting on one of the study that we did in the VA, and we actually had process maps generated over time. So we had like 15, I don't know, 20 process maps from the project, and then we could actually document adaptations by looking at different variations. So I was thinking that if you had different variations of the matrix, that would be a beautiful way to see the progression and the adaptations, and you could explain why those changes happen. So a nice way of efficiently actually documenting adaptations without documenting adaptations directly. So that's kind of another thought I had. Let me see if others are jumping in. Kara did mention that we are using functions and forms ourselves, and Claire would know this related to our consultation services. So Kara, did you want to say a few words about that? And perhaps that inspires others to come in and share of how they are using this methodology in their own work, or would they?
Yeah, I think we're using it in a very novel way in that we don't necessarily have a specific intervention. Like we have the consultation service is kind of our intervention that we're looking at, but we're wanting to use this framework to conceptualize like what types of guidance is being provided to inform future best practices for D&I consultation. So that's kind of the way that we're using it, but also looking at how you guys were incorporating the assessment tools with the providers and their clients. I thought that that was really interesting because I'm also working on a separate project where this group is looking to implement a standard for pediatric pain management. And a lot of the barriers that are coming up are kind of around alignment between the provider and the patient and also leadership. And so I thought it was really interesting how you applied the assessment of, you know, the forms and functions to this study as well. So it kind of got me thinking about, oh, maybe how can we, you know, incorporate that into our assessment of like this implementation project as well.
Thank you so much, Kara. I want to point out that Russ brought in Blue as well to add some questions. So Russ, I will hand it over to you and Blue.
Thank you. Blue had a question about the sub-evaluation. I was intrigued with that, Claire, and specifically around the use of the EHR data. I'm just wondering how well that worked for you. We've been intrigued with that and want to use that more. And actually, particularly, our thought was somewhat more for real-time data or something, but honestly, it hasn't worked that well for us either with coding. And I just wondering, Blue would be interested in your experiences with that.
Yeah, so through both this project and some of the Grow Baby practice-based research network work, so we're really trying to streamline extracting EMR data to get at you know, reach and engagement and fidelity. And it's definitely tricky, especially working with FQHCs who may have their sort of homegrown EMRs, not necessarily with Epic. So real-time developing data dashboards is like an ideal goal, but we're not there yet. But for this project, we've been able to, we're extracting the data now, and there's a lot of demographic variables that will be utilized. I'd love to come back and present on sort of what we find and how we made use of the EMR data to answer questions around reach and engagement, and fidelity and dose. And so happy to do that. But so far, we've been able to, they have sort of a really comprehensive demographic profile for their families, both for many of their children. Their pediatric patients also have parents that are patients at FHC as well. And so we're capturing and analyzing that data now. But again, I'd love to come back and present on some of the dissertation work later in the summer.
That's great. Thank you. That's super. I'm wondering with two questions about just to push a bit more for my own use or thoughts. We've just found it really variable across settings in terms of how complete or incomplete the data were on demographics. And I was also wondering particularly about social needs with the focus. Were you able to collect, were there any social needs? I know a lot of FQHCs, I think, are maybe even required to collect those now. And I'm just wondering, that seems like that could potentially be really useful.
Yeah, so we asked questions in our participant surveys around social needs and social determinants of health. So we're capturing that separately, and we're actually relying more heavily on our data. But you're exactly right. It's so variable across FQHCs and community health centers, how much social needs data they're capturing. A lot of times they'll do kind of screening and assessment, but then the follow-up of kind of social needs and is not there. And so that's absolutely an area of interest for me as well, looking at that social needs data across health systems and making sense of that. So definitely an area of research.
I love the discussion. Just wanted to point out, Claire, for your knowledge, but for everyone, that Susie Honk has now a same grant mechanism that you had for the ACES project that actually is looking at how to document social determinants of health data in a more regular way using apps and other ways in FQHCs, and Family Health Centers is the main partner. So we have locally some work that we are doing, and I'm participating in the co-creation of that. But I think that this is a big question and how it's going to change, especially if it's not going to be mandated anymore. We had this discussion that do we expect that, you know, the mandate for collecting this data will go away, and will you know, FQHCs continue to document this if they are not needing to do it because it's not easy to do.
That's fascinating, Borshika, and also a little bit disheartening to see how those things will evolve over the next 4 years. But would love to connect with Susie Hong. So thank you. That's brilliant.
I am wondering if Mustafa is able to jump in. He had a comment about dashboards. Mustafa, are you in a position to share a little bit about your experience with them? And that might be our last comment. Thank you so much.
Oh, thank you. So that I don't have much experience other than teaching. Used to teach about them in our informatics program. But the health systems, they develop different dashboards, but the people who are supposed to use it, it's important to make it like they're part of their workflow. So otherwise, it might have a great value for implementation science, but if it is not going to be part of the ongoing clinical workflow, I think that's the one challenge. And also the with the BI, most of the systems used right now, it used to be Tableau in the past, so that the simple dashboards are easy to create, but the ones are really more insightful is the one there is a little bit more interactivity, like the deep down features, etc. So that they require a little bit labor, which is not always available. Like the again, needs to be good relationship, so that some analyst can do it for the project. Thank you.
Thanks so much, Mustafa. I'm looking at time. We got a really good comment from Gretchen. So I just wanted to point both Claire and Alec to that. We will most likely not have time to fully explore this comment, but I will encourage you, and perhaps Claire and Alec, if it's okay with you, would you put your email address into the chat to connect? While you do that, I wanted to thank everyone for being here, and especially Claire and Alec for presenting on such great work. And Claire, I am excited to see that you are taking it to the next level through your dissertation. Alec, I'm sure that these ideas at least will be incorporated in your future work, and we look forward to seeing that. And everyone, thank you for being here. We look forward to connecting with you next month, and feel free to email our presenters if you had leftover questions. And we provided, as you know, the publication, the part that is published in the chat. So please refer to that as well. As always, this presentation has been recorded and will be made available. And I hope that you have a good month, and we will see you soon. Thanks so much.